Mhm. So thanks for having me tonight. I'm David Weismiller. I am a professor in the Department of Family and Community Medicine. I am part of the UNLV Medicine Practice Group, and I've been here in Las Vegas since the beginning of the medical school, or before it started, in October of 2016. And I've been in practicing medicine now. Actually, I graduated 30 years ago from medical school, actually this June. And I've been participating in transgender care now for about 11 years. And it has become a fairly significant part of my practice over the last 4 years, particularly since moving to Las Vegas. I do provide full spectrum care, including both trans women health and trans men health, and look really at whole person health as a family physician. I take care of a large number of transgender adolescents right now, and I'm doing some of that in consultation with my colleague Patel Parul, who's one of our pediatric endocrinologists. She is working with me on some of the puberty delaying, but I do cross-hormonal therapy and then all of the preventive services that individuals need related to their both sex that was given to them at birth and their gender, which is confirming for them. I really focus on whole person, and that's a really important thing to me, and I want to meet people where they are. My goal is to make the best recommendations I can make based on the best evidence that we have to promote the best healthcare decisions that you have and that you want to make. My goal is not to make your decisions. I will let you know if I feel strongly about something, that I do feel strongly about that. But otherwise, really my goal in life is to make sure that you get the best healthcare possible and that I can give you the best information to help you make the best decision for you. Getting into our practice is really simple. You can call our office at any point. Ask for me by name. Glad to see you if you are in need of healthcare or you know anybody that's in need of healthcare. Of course, we have full specialties available at UNLV Medicine. So if there are any other areas of healthcare that you're particularly concerned about, I can always get you to one of my colleagues in that particular area, whether it's, management of some particular diabetes issue or an endocrine issue, or you need some kind of surgical issue, whether that's associated with gender confirming surgery or not. Many of you maybe have met my colleague, Dr. John Brocious, who is one of our surgeons in our plastic and reconstructive surgery department. We work very closely together, and actually he and I had a meeting today. I was explaining to Nick as we were getting started, looking at how we best consolidate all of our services here at UNLV Medicine to best meet the needs of our patients, and that includes, most importantly, our transgender patients. So that's a little bit about me. Like I said, I've been doing this a long time. I've been reflecting over the last couple weeks. I will tell you, I do a lot of national speaking to train primary care physicians related to engaging in transgender care. I've got 2 meetings next month that I'm speaking at. I really am very humbled that I've been given this opportunity. I've been reflecting that 30 years ago when I was in medical school, I am certain that this word did not even come up in our lexicon. And many of us have gotten into this indirectly because of the need. And I'm just glad that I can be here and be a part of meeting the healthcare needs of individuals within the community. But really important to me is listening to where that individual is in this confirming journey. And, I've met people at various different places, and I think it's really important for me to always remember that it is not a one size fits all for people, regardless of the healthcare issue that we're dealing with. And really important for me is listening and then coming up with a plan that best fits the need of that individual. And, I have to always remind individuals, particularly as they're starting cross-hormone therapy, which is primarily a big issue for which they may be seeing me, in addition to their other primary care. But then when we're starting cross-hormone therapy, that this is a process. And we have to anticipate at least 6 months of a process to get us to some place where we want to be. And I think it's important for people to remember that typically it's about 24 months for that individual to reach that place in which I'm finally feeling I'm either there or I'm not there, and we need to make some more changes. I'm not one that tends to start out very slowly and go slowly, because my experience has been that most people want to get moving along. I'm really happy to have that conversation as we look particularly at cross-hormone therapy. So that's a little bit about me. One of the questions that Nick asked me to address, and I want to bring up, is what are the important questions for the patient to ask? And then I'll be quiet, because this is a really important thing. And one of the things I work with our medical students with is it's very discouraging to me that as I look at the literature on issues related to healthcare, the number one issue that patients have with their clinicians is that we don't listen. And that is particularly alarming to me. So here are the important questions I encourage you to ask whomever you see for your healthcare. One is, how do I access you? Okay, that's a really important issue. Is it going to be electronically? Is it going to be by phone if I can't actually get in to see you? Number two, I want you to make sure that they're asking about your health history. The third, I want them to make sure that they're asking about whether you are or are not on hormones, or whether you're thinking about cross-hormone therapy. In that context, very important for us to be thinking about cardiovascular health, because although we may not have been, for many of us, we may not have been using hormones in this particular manner for a long time. For a long time, I've been using testosterone in cis men and estrogen in cis women in order to treat various issues that they may have had come up in their healthcare. Very important to me is then that you make sure that they ask about risks for cancer. Then we also always want to think about our sexual health, think about HIV, STIs, and then safer sex. Very important, because tobacco use is the number one cause of preventable disease and death in the world. Very important that they ask and you discuss with them about that. Issues related to depression and anxiety. And not depression and anxiety because an individual is trans, just because it is a common issue. And then lastly, I always want to make sure that patients are asking about appropriate nutrition and appropriate physical activity. Because, as I said, number one cause of preventable disease and death in the US and in the world is tobacco. The number two cause of preventable disease and death in the US is issues related to weight. And how do we manage weight? Typically, we need to look at nutrition and physical activity. So those would be the 10 important questions for the patient to make sure they're asking their physician, how are we going to address this in the context of our healthcare? Okay. Questions that people have. I mean, I can go on and talk about some other things, but are there particular issues that you're interested in and how I might approach them, et cetera? I'd be glad to answer those.
I want to and thank you for sharing, and thank you for being a provider out here for the trans community. We need more people like you. So I, of course, as I said, I have a list of questions. It's pretty much the same list that I sent to you, Dr. Weismiller.
Sure.
But I'd like to know if people have any questions as far as getting to know Dr. Weismiller that you have that you would like to ask him. You can type them in the chat, or as I said, you can speak, but it is recording, so just be aware of that. I'll give it just a minute to see if
Sure.
anything pops up.
Sure.
I have a question.
Go right ahead.
Okay. Right now, for as far as like body projects, for like my presentation, one of my top things is FFS, and one of my concerns is like my downtime and recovery, and what kind of complications might I expect?
So you're planning a gender confirmation surgery.
Yeah, for facial feminization surgery is something
Yes.
I would like to be able to do in like the next 2 years.
Yes.
And as I'm like talking to different surgeons and trying, I haven't picked anybody yet, but I'm doing consultations and stuff.
Uh-huh.
But one of my concerns is like, how much downtime can I expect? Because I'm going to need to take off time from work and stuff.
Yeah.
And what are some complications that may come up? What can I expect?
Yeah. Okay. So I'm going to give you the broad view of what I've seen, and in talking with my colleague, Dr. Goldman at UNLV Medicine, who is the primary person who does facial feminizing surgery in our institution. Number one, typically the downtime for most surgeries is going to be about a week. Now, are you going to feel like going back to work in a week? That's going to be hard to predict. But in general, it's going to be about a week. The second issue that comes up is the amount of bruising and or irritation you may have. That's going to be independent. That's going to be dependent on the given individual. So that's going to be a second thing that I would need to think about. But in general, I would think about you're going to need a week from recovery. You may want to consider a second week just in terms of some of the overt attributes that may be seen as the result of a surgery. Unlike having top surgery, where you're going to have something over top of you, your face is right out there for everybody to see. And I'm not saying you can't go to work or wherever you have to do with some bruising and redness and things like that, but typically people are a bit more sensitive to that. Now, the third thing I would just remind you about here is that the issue here also is some surgeons will want to alter the estrogen dose because you're going to be potentially incapacitated for a little bit. That varies from surgeon to surgeon. The one thing I would encourage that if you are, and you don't need to disclose what your vehicle of estrogen is, in terms of whether you are taking some type of oral or sublingual or injection. But a lot of times if patients are taking oral sublingual, I will move them to a transdermal patch if there's any concern about that there's going to be too much downtime. Now, typically with FFS, there is not a lot of downtime, so most surgeons do not have you alter your estrogen. This comes up more often in some of the genital surgeries where they'll want you to alter your estrogen, and they'll take people off of their estrogen. I don't recommend that, but your surgeon's going to have that final say with you. But if there's any discussion there about going about that, I would have a discussion with him or her about potentially moving to a transdermal patch if they want you to stop the estrogen altogether. Now, there's no reason you can't stop the estrogen altogether, but some people prefer not to. And in those patients, I typically recommend a transdermal patch.
Thank you. Ray had a question,
Yeah.
which is, what would be a quick breakdown that you would give to someone who wants to get started on hormone treatment therapy?
Okay, so the quick breakdown in terms of you come into the office and you say, I want to get started on estrogen or testosterone. Is that what we see about a quick breakdown? Or are we talking about what are the side effects that I need to be worried about?
It sounds like they were meaning like a quick breakdown of what the simplest way of what the process looks
Okay,
like.
that's fine. Okay, so you come in, we have a discussion about where you are in life. And, I have patients who say, listen, I'm a male. I don't care what they told me at birth. I'm a male. And I'm 22 years old, and this is where I am. We have a discussion. In the old days, people used to be sent to a mental health provider to confirm, et cetera, et cetera. We don't do that anymore. There are some providers that do that, but really the movement has been, if you're a competent provider and you're seeing somebody who is used to providing care to transgender individuals, we have a discussion. And if there is defined gender dysphoria, then we start moving forward with hormone therapy. We look at risk management in terms, or risk stratification in terms of issues such as cardiac disease or bone health. et cetera. We have to think about preventive health screening. But I will tell you, most patients who are coming in to see me, who are well on their journey, we start hormone therapy that day. Now, in terms of the risk benefits of starting that hormone therapy, well, before I get there, let me just say, if somebody comes in and says, I don't know where I am, I don't know if I'm gender nonconforming, I don't know if I'm gender fluid, I just don't know, I'm just in a place I don't know, then we have a discussion about that. We look at other risks, look at other resources that might be available to the person to help them in this discussion, because it takes a community of us. But if we have said, this is where I am, I've been on this journey now for 10 years or 15 years, and I want to start hormone therapy, then we actually review. The World Professional Association for Transgender Health, WPATH, has Appendix B, lays out all the risk benefits. I have that all in a document. I give the patient time to read through that. If they want to go home and read through it, great, we'll come back for another appointment. If you want to read through it in the office that day, we'll read through all of that. I answer any questions. We both agree to signing that, and we put forward the medication that day. If you're 16 or older, almost never do I have a problem getting hormone therapy started for the individual with the third-party payer, i.e. your insurance. If you're under 16, because I have individuals who are under the age of 16 who have gone through puberty. They have not been on pubertal blockers, but they've gone through puberty. If they have gone through puberty, we can start hormone therapy at 14 or 15. I don't use age. Well, there's only one society that recommends using age. That's the American Endocrine Society. I don't recommend using age as the only point at which we decide whether we should start hormone therapy or not. But we read through that document, we have a conversation, and we get started on therapy. There'll be a few labs we'll do at that visit. Most labs we have to then follow at 3, 6, and 12 months. If those are stable, we just have to do them once a year. And typically for the first year, I see people every 12 months when I'm starting hormone therapy. After that first year, if things are stable, we're not making adjustments, I typically will see them every 6 months. I have a couple patients right now. They have been on hormone therapy well before I knew them. They've been stable the 4 years that I have been privileged to care for them. And I only see them once a year now, unless there's a health issue that comes up. They are otherwise healthy individuals. And this in and of itself does not, in the absence of specific risk factors, necessarily require any further monitoring than they would have as if they were a healthy individual who was cisgender as opposed to transgender. So that's basically the process. We have a conversation, we have an agreement, we review the risks and benefits, we get the medication started. Like I said, if you're under the age of 16, the insurance company is always going to throw up a red flag, and I have to work with them directly in order to get those approved, but that's what I do in life. And we have the resources available that we can do that, and we can get patients started on that. And then 3, 6 months, 12 months, and then typically every 6 to 12 months thereafter. So there's not a lot of blood drawing, which is good. Okay, is there a way to get insurance to pay for electrolysis, for surgery or not, speech therapy, vocal shaving, facial surgery? Yeah, those are the difficult ones, I'm going to tell you. I think we're going to be seeing some improvements, hopefully over the next 4 years, as the Affordable Care Act matures into what I would say is version 2.0. We've been through 1.0 and then negative 1.0. But I think as we move into some semblance of 2.0, I think we're going to see some of these things paid for more often. I think there are ways in the context of understanding particular issues related to, for example, speech therapy or electrolysis. If there are other variables that are health related associated with those, which sometimes we can document, that helps us to, with integrity, be able to put forward this is an important issue for the patient to have resolved. But they are a bit more difficult. We're getting better with the surgery, top surgery, bottom surgery, but the vocal shaving, the facial surgery, Those are a bit more difficult. Speech therapy, I always have to do what's called a peer-to-peer. I got to talk with the insurance company, their physician at the insurance company I have to talk to. And with electrolysis, I will tell you, I have yet to be successful with that. I have been trying, I have gone to bat for several patients, but I have not been successful with that particular one. But I think what we really need to bank on here is looking at where the Affordable Health Care Act goes. And if we can get a bit more from that, I think that that will help us out as we look at some of these other options. Yeah, so when you say start the same day, when I started 4 years ago, my doctor asked me some questions and gave me a prescription to get testosterone from pharmacy and bring it back 2 weeks later, then get my first shot. Do you all have hormones in building? No, we don't have hormones. We don't keep them in the building. So you would get it from the pharmacy, but anymore, I just have the pharmacist show you how to do the injection. You do the first injection right there with the pharmacist. So you don't have to come back and see me. If you want to come back and have our nurse or MA show you how to do the injection, you can do that. But these are really simple anymore. The needles are so tiny, et cetera, that most patients are comfortable giving that first injection just after the pharmacist shows them how to do it. And I have not had any patients come back and say, my pharmacist wouldn't show me how to do it. So when that nice person at the checkout says, hey, do you have any questions to talk with the pharmacist about? I ask the patient to say yes. And then I just say, can you show me how to administer this the first time? Pharmacists are licensed to give immunizations. They give them all the time. So they're quite adept at being able to instruct people on how to give them. Okay. Right. Okay.
So I think when you were speaking earlier about when an individual comes in either questioning or they do know that they're non-binary or they do know that they're agender or bigender, and they are interested, they don't want to do the full amount that you would do for a trans woman or a trans man, but they want, we've heard things such as microdosing. Is that something that you do?
Yeah, you can do microdosing. So, you can put people, for example, on estradiol. Typically most patients are started on 2 to 4 milligrams a day. The maximum is 8 milligrams per day. But, I've got one patient right now who takes 0.5 milligrams per day orally. I have one who's taking a very teeny tiny dose sublingual once per day. I recently had a new patient. She is 63 or 64 and gender fluid and has been on a very tiny dose for the last 10 years. So yeah, I mean, those can be done. I think it's all about meeting that individual where that individual is. Keeping in mind that some of the side effects when we're dealing with testosterone or estrogen are non-reversible. This is unlike when we are blocking puberty. Those medications, you can reverse that by stopping it. Puberty will proceed, maybe 18 or 19, but it will proceed. But we have to be careful. Now, the other thing to remember, though, also is that if you are, for example, on a microdose of testosterone, well, any dose of testosterone, you've got to be very careful because testosterone will not prevent pregnancy. So in many of patients who have been on microdoses of testosterone, not as common as microdoses of estrogen, really thinking about sexual activity, desiring a pregnancy, not desiring a pregnancy is a really important piece. And, now with long-acting reversible contraceptives, we have an easy way for most individuals to be able to have the contraception they want. Testosterone, for most patients, after 6 to 9 months, they will cease having periods. But if that continues to be a problem, we can either use an intradermal implant in the arm, or we can insert a Mirena intrauterine device. Some patients will elect to have a hysterectomy. That would be an option as well. Yeah, do you discuss fertility options, impact, and strategy? Very important here. This is a really important piece, and I think making sure individuals understand if there is going to be the desire for fertility, what that means in terms of either when you have suppression of testosterone, et cetera, what that's going to mean in terms of the ability to get pregnant or the ability to conceive or the ability to conceive, or yes, or the ability to get pregnant. So that discussion is a really important one I have from the very beginning, just to make sure that people understand that. And if there's any concern there, we need to consider, do we need to do any type of banking in order to make sure that the appropriate genetic material is available if somebody wants to get pregnant? And what are the different ways to take hormones? Well, that's a really good question. I mean, you can take them by mouth, orally. We can use them sublingual. We have patches, and we have injection. We have creams, and we have gels, the latter two for testosterone. In my mind, I'm always thinking the easiest thing would be, for me, if I were doing it, would be to take an injection once a week or once every 2 weeks. I've had 2 patients within the last month who have both come in and said, I do not like doing testosterone injections every week or every 2 weeks, and I want to be put on the testosterone gel or the transdermal patch, which I have to use every single day. Fine. If that works for you, I have no problems, because again, we're going to titrate to the effects that you want to see. And I think that's an important piece here. A lot of people come in warning hormone levels. The recommendation is, after the first year, not to be checking hormone levels. If something is not right because you're not feeling right, that would be the time I would be checking them. But if you are otherwise feeling fine, the recommendation, given the current literature we have, is not to be doing routine hormone checks. And that can be really costly to the patient, because a lot of that will come out of pocket many times. So typically the things I'm doing on trans women, since they are on an anti-androgen like spironolactone, I am checking their electrolytes, sodium, potassium, their kidney function once a year. And in trans men, because testosterone can drive up your blood count, the one thing you have to check every year is a hemoglobin or a blood count every year. But otherwise, I try to dissuade patients who are feeling otherwise well and comfortable where they are from doing a lot of hormone levels. Because after the first year, they don't really have a lot of benefit in telling me where you are. Because if they are technically too low, but you are feeling fine, I'm not going to change anything. If they're technically higher than we would like to see, but your other blood work, i.e. electrolytes or kidney function, or your hemoglobin and hematocrit, that's your blood count, are normal, I'm not going to worry with the numbers. Okay, we don't have a lot of data on what these numbers what they mean, but a lot of people, particularly patients, like to see numbers because it makes that more real for them. So we have a discussion about it, and we can come to some conclusion about what best meets, an individual's needs.
I actually, I have a question to go off of that. I just recently, about a year ago, switched over to pellets because I've been on testosterone for 4 years, and after 3 years, I was just done with shots. For the first 8 months, actually, because I'm terrified of needles, I had my my grandmother, who used to be a nurse, do my shots for the first 8 months before I.
Oh, really? Okay.
And before I switched to pellets, my doctor had mentioned something that I didn't even have a chance to look at because I just wanted to switch to pellets already. But he said we never looked at it. We never got in real depth detail about it, but it was kind of like an EpiPen.
Yeah.
So pretty much there was something new coming out to where it had the testosterone or hormones in general already placed inside of it, and you put it up against wherever, you press a button, it takes a minute, pops back out, and then it's done, and that's done. Do you know of that?
Yeah, so we have a lot of pens that are available for different injection medications. I have not seen yet any detailing on the two. There are typically 3 different forms of testosterone we use: cypionate, ethanoate, and the undecanate. And I have not seen anything detailed on those yet with a pen. Now, that doesn't mean it doesn't exist yet, but typically when I'm ordering these, I have a menu of testosterone preps that come up in our order system, and I have not seen that yet as an option. And it's interesting because I recently was looking through all of this because I had a patient who wanted to switch to the testosterone patch, which is sometimes hard to get paid for, but his insurance was covering it. So I was looking at detail of all these. So I've not seen the dial-in pen. We use that a lot in diabetes now because it's just so much easier. But I'll take a look at that and I'll get back with you because I have not seen it marketed yet. Okay, do you write letters for name or gender marker change? I have. This is an important thing. It's very important to us in the office to make sure the health record reflects and confirms the patient's name and gender. This is something that I have done. It's very straightforward. Usually there is a form in most states that needs to be completed by the physician. It varies in terms of time that you've had a relationship with the patient. I have had one patient who came in on a very first visit who wanted this done. I typically want to see somebody at least twice before I do this for them, just to make sure that I'm comfortable with them and they are comfortable with me, because it's a two-way relationship here. And I want to make sure that that's going to work. But, I think having that marker changes is exceedingly important that I have found. And, that's a fairly straightforward process. But again, in my practice, typically when I'm filling out forms, I'll have wanted to see the patient 2 times. So for many patients, that's going to typically be an intake visit, and then usually 12 weeks later. Sometimes it's sooner if we need to do something sooner than that, but usually it's 0 to 12 weeks. If I'm starting them on that initial visit on hormone therapy, I do see them back at 4 weeks just to see how they are feeling on that. In terms of letters for surgeries, so here we're thinking about risk stratification. Most surgeons are still, and this is what I'm finding, most surgeons are going to want to have a letter from a mental health provider still. This is not what the literature recommends. And of course, I think it's Medicaid, don't quote me on this, requires you to have been living in the confirmed gender for, I think, 2 years before surgery is allowed, but don't quote me on that one. Dr. Brocious will be able to answer that for you better. But I know, for example, he and most of my colleagues I have found have wanted that letter from a mental health provider. This is evolving. And part of this is, I have to admit, part of this is going to be medical legal, and we have to recognize it is what it is. And part of this is just an evolving comfort. So I think, like anything, although transgender is not new, the issues in terms of providing optimal health care and looking at the literature on providing the best health care is evolving and new. And what's really unfortunate is that when something is ready for practice in medicine, unrelated to gender or sex, when something's ready for practice in medicine, meaning there is good data to support it, it has become the standard. The data all shows it takes 10 years for us in the healthcare profession to fully adopt it, which is pretty scary when you think about it, that there could be something out there right now, published, ready for use, and it will take 10 years potentially to be fully integrated into the healthcare system and to be used. I think we're getting better with that, but I still see that. And I see that come up a lot when I'm talking with learners, that they, ask them a question or they'll discuss something with me, and they'll discuss something that we did 7, 8, 9 years ago. And I'm like, you're a third-year medical student. You shouldn't even know about that. However, it is where the issues are arising in terms of how long it takes for something to be adopted. Oh, and Ray put something up there. That's good. So this is Health Plan of Nevada and what their summary is in terms of what you need prior to surgery, I guess there. Okay. Yeah, consistent with the gender identity, right? And this is exactly what the surgery is going to want to see. Exactly right. So yeah, they use at least 12 months in the WPATH. John was just speaking on this last week, and he uses, if I recall, he and I gave a grand rounds at our institution. He uses 24 months, and that's what I said. I was a bit surprised, but some things do take a bit longer to change. Yeah.
So I was recently speaking with someone, and I think they were actually going to sit down with Dr. Brocia. So they'd had a consultation, and I know that it's not required by law to have the letters, but more on the doctor's discretion, if I'm correct.
Right. Yeah.
And so he had asked for them to get 2 letters, one from a mental health professional and one from a primary care provider. But sometimes they ask for 2 from 2 mental health professionals, but that's kind of difficult unless someone's seeing both a therapist and a psychiatrist, because you can't see 2 therapists at once.
Yeah, you would be getting a second opinion. Yeah, the reason I'm asked typically to offer a letter is to document the use of the cross hormone therapy living in that new gender role. So those letters I do write, and typically they want me to confirm as that I've been prescribing that for at least 3 months. So those letters I do provide. I've not seen anybody, although maybe they do. I personally have not seen anybody require 2 mental health provider letters. But again, I'm not on that side of the surgery aspect of it. I'm on the side from the standpoint of providing the letter that this individual is consistently living in this gender, and that I have been prescribing and can document that I've been prescribing cross hormone therapy for this period of time. And that's usually what I'm asked to do. And then there's a second one in terms of risk stratification for the surgery itself, any recommendations from a healthcare standpoint that I would want to make.
I was gonna type it, but so with that, are you then also able to write, can someone come to you to get a referral for a consultation for surgeries?
Oh yeah, definitely. Definitely. Now, remember, to get a referral for any type of procedure, you have to establish care with that primary care physician, and then they can do the referral for the surgery. That's not a problem whatsoever. Yeah, I mean, that's part of the discussion I have. I have some patients I've been taking care of for years now. They're not interested in any genital confirming surgery. Or gender confirming surgery, which is fine. But I always ask individuals when we're having this ongoing discussion at the beginning, are we thinking about it? Have we thought about it? We've ruled it out. We want to rule it in. It may come at some point. I just want to be supportive in being able to help answer the questions in preparation for that. The individual will know, and they typically do know, whether they want to have surgery or no surgery. And I just want to be supportive of whatever they think is the best decision for them. Insurance, we take almost everything. There's little we don't take at UNLV Medicine. So whomever is out there who wants to be a part of our practice, feel free to call. They're going to go through all of that with you just to make sure, because there's sometimes some variations even within a particular payer. But it's rare that we don't take, or that we have a person who is not credentialed with a particular insurance company. So any of them are accepted. And if individuals do not have any third-party payer, as part of a state system, we have a sliding scale fee. And those in our business office are happy to work with individuals to figure out how they can best utilize that sliding scale fee and set up any type of payment plan that works best for their budget. So we've got those resources there. Do they let people know if you're their insurance, but their insurance doesn't fully cover your practice because it's out of network. Oh yeah, definitely. Definitely. You would know if we were in or out of your network. They're going to be able to tell you that because the copay would be different if you were out of network. So they'll be able to tell you that before you're seen, before you even make your appointment. And you can specifically ask that if there's any concern. And then always you can double check with your own insurance company too, and have documentation both from us and from them that there's not going to be a problem in terms of payment, because that's a huge issue. I mean, it's a huge issue in healthcare in general. Okay, yeah, call the number on the back of your card, definitely. You always want to make sure that any provider there, so whether it's for primary care or mental health, those numbers are really important. That will allow you to confirm that an individual practitioner or practice is credentialed in your healthcare system to assure that payment is going to be appropriately accepted. That's a really important piece. Yeah. Okay, let me just see.
Oh, was there another question?
No, I was just wondering if there was anything else you had asked me to comment on. I was just looking down that list you had sent me.
That's what I was pretty much throwing in the chat.
Yeah, I just wanted to see that. Okay, so can they ask for anyone under you? Are there others that they should ask for? That's a really good question. For right now, and Ray and I have discussed this at an earlier time too, so I'm glad that he brought this up. Right now, best to ask for me. We have several of our physicians who are residents in training who are very adept at seeing transgender individuals, but that may not be as identified readily in our appointment system. And therefore, what I would not want to happen is for you to call UNLV Medicine, get to the Department of Family Medicine, and somehow get to a provider who does not feel comfortable providing hormone therapy and transgender care related to cross-hormone therapy. Anybody in the department will be more than happy to provide primary care, general health care. That is not an issue for anyone. But in terms of some of the issues related to cross-hormone therapy, documentation of gender, in terms of surgery, gender marks, etc. For right now, I would suggest that you just ask for me specifically, and they'll get an appointment. And we can always, if the individual would prefer somebody else, I can always get them to another provider who I know specifically provides cross-hormone therapy, feels comfortable doing that, feels comfortable doing the monitoring, and will be another resource for you.
So back to the injections. So recently, through the doctor's office that I go through, they've had lack of availability for to give shots to people. So like for those that don't feel comfortable, are scared of needles, just there's usually someone in the office who before you could walk in at any time. It didn't have to be your first shot or anything like that. Like if you needed someone to do your shot, you were able to walk into the office and have someone do it for you. But now, because there's a lack of availability for people to do that, you have to schedule an appointment to get your shot. What does the availability look like in your practice?
So typically, just to make sure that we have somebody there to do it and the patient is not waiting, we usually give them a nurse appointment. Because that facilitates, because we're very respectful of people's time, and we don't want you, showing up at 9 o'clock and we have 10 patients coming in and you've got to wait for 30 minutes as our nurses and medical assistants are rooming 10 patients. So that's the reason we like people to have at least just a time slot on that appointment schedule, because in that way, that individual is not kept waiting, because I personally and our staff is very, very sensitive to patients' time, and we just don't want you to wait. So that would typically be the issue. If somebody showed up unannounced that needed their testosterone injection or their estrogen injection, we would get it done. It's just that the individual may need to wait a bit longer just because of conflicting work going on in the office. There might be a procedure going on and people are being pulled in other directions. So we want to be flexible with individuals, but we also need to be realistic and respectful of time. And that's why we typically prefer people to have at least an appointment slot with one of our MAs. You do not need to be physically seeing your provider in order to get that done, because those are just, if that was there, that would be just a standing order for them to give it to you. And that we have that all the time. I mean, I sign off on standing orders for example, for testosterone injections in individuals, not infrequently. Good question. Yeah, so this question had come up. I think Dr. Brocious brought this up to me several weeks ago. He asked me about intersex healthcare. I'm happy to do that. I have several patients right now. Over the course of my 30-year career, I've always had at least one, if not more, in my practice. So it's nuanced, but fairly straightforward, and happy to assist any individuals who identify and find themselves in that intersex realm. So yeah, I would be happy to see them. Any other questions or comments I can make? I'm just flip through your questions here just to make sure I didn't miss anything. I just will say one other thing that I have found really difficult recently. I've had a couple of my trans women patients who have had erectile dysfunction, low libido, and I've been dealing a lot with insurance companies now about getting 5-phosphodiesterase inhibitors for them. These are things like Viagra, Cialis, Levitra, et cetera. So that's one of the things that I've been looking in with Medicaid to see how we might be able to start a conversation with a larger group, because this shouldn't be happening. So I just want people to be aware that if they are interested in that, because they're completely appropriate to use, that there are some insurance issues which have come up. And this is an ongoing conversation that we're going to need to have. One we had this afternoon as we were discussing this, in terms of resources within a potential emerging center here, as to how we provide, total care. And this is one that we're really working on, and hopefully we'll be able to get some movement. But I think it's going to require a larger organization like Nevada Medicaid to help us in doing something like this. But just kind of crazy that that some of these are being refused. So, but we're working with the insurance companies on that. So, anything else I can answer? Has this been helpful?
I think it's been absolutely helpful. I think
Excellent.
that you've given a lot more information than I thought you were going to give, which is extra great, a cherry on top.
Oh.
And I think that this will definitely be beneficial to those that weren't able to make it tonight as well. I appreciate you being willing to be recorded so that this can be more accessible for people.
Oh, sure. And, if I could ever come back, for any discussion at any point, always happy to do that. And hopefully once we are past this pandemic, we'll be able to meet physically. How long does it take to get an appointment? New patient appointments, they vary, but definitely under 6 weeks typically. Most patients can get a new patient appointment, usually within 2 to 4 weeks in the practice. I see patients typically 6 half days a week, so I'm there every day in the office. So typically they can get in to see me. And if there's any problem, they can leave a message. We'll be glad to work with the schedule to get them in, not a problem whatsoever. Okay.
Well, I think coming up into the last 5 minutes, I want to respect your time. I really do appreciate you giving
You're
us
welcome.
your time. And again, being a provider here for the trans community, it really means a lot. And I appreciate you speaking on, what you do. So